for them. At World Remit, we understand what the journey is about, how it can sometimes take a little distance to bring us a little closer together. With ways to save more when you send more, World Remit is here for you, so you can be there for them. At World Remit, we understand what the journey is about, how it can sometimes take a little distance to bring us a little closer together.
This program is brought to you by World Remit, a fast, reliable and better way to send money.
At World Remit, we understand what the journey is about, how it can sometimes take a little distance to bring us a little closer together. With ways to save more when you send more, World Remit is here for you, so you can be there for them.
Hello, welcome and good evening to you all, our audience for today. Welcome to the third edition of the Ghanaian Community Awareness Forum. Today is an interesting day because we'll be looking at issues that we all have so much dear to us. It is to do with chronic diseases, the impact of the virus, the pandemic on our lifestyles, and how best we can gain the knowledge and information we need to be able to maintain and sustain our lives as we continue to find ways to overcome the situation. I would like to mention that this event is brought to you in partnership with the Ghana Union, UK and Ireland, the Ghana Nurses Association, UK, the Western Regional Association of Nurses, UK, and the Nightingale Ghanaian Nurses Association, UK. I will be your moderator, and my name is Emmanuel Kwesi, the chairman of Ghana Union, UK and Ireland. We also want to acknowledge the support of our sponsors and promoters of this event, World Remit Money Transfer, an easy, reliable, fast, and efficient way of sending money to loved ones, family, and friends in Ghana and around the world. We have the support of Omega Live, who is streaming live across Facebook, YouTube. We also have the support of the Ghana High Commission, who is the overseer of all Ghanaians here on behalf of the government of Ghana. We have the Ghanaian Doctors and Dentists Association also supporting us. And let's also not forget that we have all Ghanaian community groups affiliated to Ghana Union UK umbrella also as part of the effective partnership. This evening, as always, we will have to go through a few rules to make sure that by the end of the night, the purpose of the function meets the usual standards. And so all audience will be muted throughout the event, except the host. No self-unmuting access will be given to anyone throughout the evening. The moderator will do so as and when you are called to ask a question. Audience will not have the right to share their screen, and that is one of the basic standards that we need to adhere to. Those who have sent us advanced questions will have their questions asked, and if you want to still send your questions, please feel free and send it to my mobile number, which is 077-343-12820. 077-343-12820. You can also go to Zoom chat and raise your hand there, and then your questions, you can also put it there, because we also have somebody who is qualified enough to articulate your answers over there as well, and where possible, the person will determine whether to bring it to the main forum or not. Please, at any point, if you are called to ask a question, let's go straight to the point, so that we give time for others who will also otherwise want to ask their questions. So these are a few house rules that we hope you will kindly help us to achieve in the course of the evening. And I want to welcome all of you once again to the third edition of the Community Awareness Forum. On behalf of the Ghanaian community and on behalf of Ghana Union and all our partners, I also want to wish you all a happy anniversary of Ghana, 64 years on the 6th of March. And as we are in the month of March, every day of this month is our anniversary. And so those who have joined us, we wish you all a happy Independence anniversary. I'll go straight to introduce my panelists for tonight. Today, we are lucky to have with us experts who are versed in their field. They have been in the room there where it happens and can now share the knowledge and the ideas that they believe will help us as a community to gain the information that we so well deserve. Tonight we have Dr. Vicky-Moxam. Dr. Vicky-Moxam is a kidney consultant nephrologist at Guy's and St. Thomas's Hospital. Dr. Moxam, welcome to tonight's show. Dr. Moxam will seek to look at impact of COVID-19 on chronic diseases most associated with the BAME community groups, diabetes, kidney, or any other type of illnesses that she believes she needs to address with us tonight. She will, where possible, also look at some of the statistics of areas where the COVID has impacted on many lives since the pandemic took its course last year. We also have Dr. Osei Kojo-Kankam. Dr. Osei Kojo-Kankam is a consultant respiratory physician at East Success Healthcare NHS Trust. Dr. Kankam, welcome to the show. Dr. Kankam will take us through and reflect on COVID management, the post-COVID syndrome, long COVID, and its impact on chronic diseases. And also being somebody who has been in the ICU and wherever all the critical situations has been dealt with, can share with us how important it is that we engage in the ongoing situation when it comes to the vaccination, just to help us reduce the risk of finding ourselves in that scenario. So good evening, Dr. Kankam. Thank you for being with us this evening. We also have our panelist three, Sedna Agama. Sedna is an Associate Director, Medicines Optimization, Chief Pharmacist for Southwest London Clinical Commissioning Group, London Borough of Merton. You're welcome, Sedna. Thank you for being with us. Sedna will seek to speak to issues about vaccine facts, any myths that people still have, challenges that people have with the vaccine, any questions that you have in relation to the vaccine itself and how the vaccination campaigns are going on across other communities, including our own. So Sedna is well versed to tell us as much information, so feel free to put your questions as you find it fit. And then we will have in the chat room our panelist 5, who will be Effa Moti. Effa was with us last week. Most of you would have listened to her. So when I said we have somebody there who knows what she's talking about, Effa will be in the chat room throughout the first hour of this session. Effa is the Deputy Head of Medicines Management, North Central London Clinical Commission Group in the London Borough of Haringey. And she will be going through all your questions there. And then wherever she finds a question that she thinks it will be interesting for most of you to obviously understand, she will join the panel an hour later and share with us. So on that note, I want to welcome all of you once again to this third edition of the forum. And I look forward to you all engaging with us, working with us to get the information and the knowledge that we need for the good of our community. We will, at this point, run a few polls in the course of the sessions. Before we do that, as has always been our custom, let's pay homage to those that was once upon a time with us a year ago, and for no fault of theirs or for whatever the reasons, they are no longer as a result of the pandemic. So for a minute's silence, wherever you are, I just hope you will join me to observe a silence in memory of those we have lost. Thank you. May the souls of those who have left us rest well, and may their passing be a blessing and a memory to many of us and their loved ones. So we'll run our first poll. There's no name, no indication of any detail, no personal details. We just want to find out as a community where we are when it comes to the issue of the vaccination. Please, we need you to help us to understand it so that as we continue these programs, we'll be able to tailor it to your needs. Thank you very much. As you can see, we have now finished the first poll. So we will go straight now to the panel presentations. And we will call on our first panelist, Dr. Vicky Moxham, to take us from here.
Good evening, everybody. Thank you very much for inviting me to join with you this evening to talk about this really important issue. My experience with chronic diseases and with COVID-19 has really very much shifted everything over the last year, as it has with many, many people, I'm sure. I work in the remit of chronic kidney disease, so that's people who have kidney failure, both early stages, late stages, and people who have transplantation, all of which are at high risk and have a very high disease burden in the context of general life, as well as within the particularly in the context of COVID, which is what I hope I'll be able to share with you today, some of the data around that. I'm also going to talk about the risks around chronic diseases and COVID and what I feel is the relevance of this. And I want to try and share with you some of the early data around the impact of the vaccination programme, and also outline a little bit about what we can do to just try and help support ourselves and patients and people and individuals who do suffer with chronic diseases, about how self-management can actually really empower you to look after yourself and keep yourself well, particularly in times of stress as we're facing at the moment. We can go on to my first slide. Next slide, please. Thank you. So there's a lot of data on these next 4 slides, but I thought it was really, really important to highlight this to you. So these come from the Oxford group, who were looking at the risk factors for hospitalization after contracting coronavirus in the first wave, and what it was that was putting people, or what the features of particular individuals that meant that they perhaps were likely to have more severe disease, i.e. be hospitalized, or even unfortunately die as a result of coronavirus. Now, things that aren't included on this is age, so that it's very, very striking. Up until the age of about 60, the mortality rate is extremely low. After the age of 60, and particularly from 65 upwards, it goes almost vertically upwards. So by 75, you have a 50 times risk of that of a 40-year-old of dying as a result of contracting coronavirus. And by the time you're 80, it's 100%. And by the time you're 90, it's 400%. Of course, people in their late 80s and 90s have a very high risk of death anyway, but still. The other thing that's quite striking is the increased risk of a high BMI, and there's quite an increase in your risk of having a bad outcome and passing away as a result of coronavirus, which increases from a BMI over 35 up to about a 1.5 increased risk to 3 times increased risk if you have a BMI up to 45. So the next 4 slides will show you, so this is men, and this is the risk of death. And the things that are very, very striking, particularly for me and the people I look after, is that if you have chronic kidney disease, you have between a 3 and 8 times higher risk than somebody who doesn't have kidney disease. If you have a diagnosis and live with sickle cell disease, you have a 6 times higher risk of dying as a result of contracting coronavirus than somebody who doesn't. And similarly, diabetes is between 4 and 6 times, depending on the type of diabetes you have. The diabetes statistics are not stratified by control or by complications. If we go on, and then there's a variety of other conditions, and in the vascular diseases, that would include hypertension and the complications of hypertension. All of these things sit on the right-hand side of the middle line, which means that they confer an increased risk. It adds up as you go through and you tick the box for everything or for additional conditions. So communities where there's very high risks or high incidence of sickle cell disease, diabetes and kidney disease, that becomes an incremental risk of not doing very well following infection with coronavirus. If we can move to my next slide, this shows hospital admissions in men, hospital admissions in women. You can see all of the risks are increased between 3 to 4 and up to 7 times. It's slightly different between men and women with sickle cell disease, affecting your risk of hospital admission or severe COVID in women slightly more than men. Whereas diabetes is a higher risk in men than in women, similarly with kidney disease. We go on to my next slide. Thank you. So the other risks with chronic diseases and contracting coronavirus, or in fact the impact of the pandemic and the changes this has incurred is that anyone with a chronic disease is at a much higher risk of severe disease needing hospital admission. You're also at a higher risk of dying as a result of coronavirus infection or COVID-19 disease. There's also, in addition to that, the risk of disruption to what we provide as routine medical care. The complications of the chronic diseases are not being managed in the way that we would ideally like, because there just isn't the resources at the moment to be following up patients, and there's a reluctance to attend hospital as well. There's also less perhaps monitoring of and encouragement, and therefore a slightly higher risk of poor management. There's potentially later diagnosis of conditions and therefore later intervention and treatment. There's also the fear of attending hospital and the primary care for monitoring, and I think all of these will have consequences in the years to come as a result of the pandemic. There's also the risk or the consequence, and I think one of my co-speakers is talking about this in more detail, of developing a condition which is sort of prompted by the coronavirus infection. And CKD is something that we see, and even the requirement and need for dialysis and developing end-stage kidney failure as a result of COVID infection we've been seeing, and similarly with diabetes. You can go to my next slide, please. So the relevance of this is it has a very significant health impact for groups of patients who do have a higher burden of these chronic diseases. I think it's very well and very clearly highlighted by the delay and the increase in the waiting times for surgery. We're looking at 300,000 people now have a delay of more than a year to their surgery, having only been 1,500 or 1,700 a year ago before the pandemic started. It's unknown the amount, but I fear that there is a significant impact on the chronic disease burden in communities where we do have higher instances of these diseases. And also this will have a subsequent impact on the longevity, both of the cumulative morbidity, so how well people are day to day, and also their risk of dying early as a result of these conditions being higher. Next slide, please. So this is the sort of positive side to what we've been able to do. So because the vaccination programme is only really quite young, we've vaccinated 22 million plus people in the UK now, but there isn't much data now at the moment about the impact of this in the general communities. However, where we do have data is in the NHS workers. We were vaccinated or offered vaccination earlier, and we also have a higher exposure because we are in contact with patients who are suffering with coronavirus and looking after them day to day, and therefore you'd expect a higher incidence in this population. We are also all offered, and most of us get undergoing routine surveillance testing. So even if you have very mild disease that you don't know, or even asymptomatic disease, this is picked up. So we've seen a very dramatic 50% reduction in the rate of infection in those vaccinated versus those not vaccinated. There is also evidence of far milder disease with less hospital admissions and a lower mortality. And this is very, very striking reduction in a burden of these diseases. And it's over the same time period, comparing healthcare professionals who have been vaccinated versus the healthcare professionals who haven't been vaccinated over the same time period. Next slide, please. So what can we do to try and help ourselves, all of us? It's essential to manage any of your pre-existing chronic diseases well. Don't be put off by the fact that, maybe the traditional paths into seeing your GP or having the support that you'd expect aren't there. Don't let that stop you. Medication adherence is always vital. It is always a negotiation and a partnership between you and the healthcare professional who's managing your chronic condition, but it is essential. And monitoring is essential. That doesn't necessarily need to be by formally coming to a clinic appointment. This can be done yourselves, and utilization of home monitoring is essential as well. I think it cannot be emphasized how much a healthy lifestyle can help the vast majority of these conditions, reduce their progression, and also help with keeping active and well longer. It is vital to attend hospital appointments. This can be scary, and with my patients who have no choice but to attend their hospital appointments, I know this has been a real burden, both emotionally and physically, over the last year. Obviously, we all need to follow the advice around shielding, social distancing and hand washing to reduce the chances of getting the virus, because obviously if you don't get the virus, it doesn't carry the mortality or morbidity that we see. And of course, it goes without saying, the vaccination against the coronavirus is absolutely key to the future for all of us in protecting people with chronic diseases. Next slide, please. Thank you very much for your attention. I'll hand back.
Thank you, Dr. Moxam. Thank you very much for such a clear indication of how the situation look like. We will move straight to Dr. Osei Kojo Kankam, who will take us through the respiratory aspect of the situation. He's been there along with I'm sure along with Dr. Vicky and others, but he's here to share with us his own version of event and how he can encourage us. So, Dr. Osei Kojo, please take the floor with us.
Thank you. Thank you for inviting me to speak today. I'm very honored to speak to my fellow Ghanaians. My name is Osei Kojo Kankam. I'm a respiratory consultant based at East Sussex Healthcare NHS Trust, and I work on the South Coast in Eastbourne and Hastings. I thought I'll share some of my reflections about COVID-19 and then talk about something to do with long COVID. A year ago, we had no clue what COVID was. We heard on the news from China in January last year. And then by the end of March, a big tsunami hit the health service. And from a hospital where it was bustling with people walking along the corridors, everybody in the coffee shop, in the dining rooms, etc., it became a ghost town. And the car park was almost empty. And the effect on us as healthcare professionals was enormous. Going to work, initially getting PPEs to look after patients was a big problem. And then the other issue was not knowing how the infection was going to play out. And people were coming in, and it took us 7 days to get test results back. And unfortunately, it meant looking after patients who may harbor the infection in places where they weren't meant to be looked at. As a respiratory physician, the majority of my work had to do with people who required oxygen. Now, with COVID, as we know, the knowledge as we have now tells us that about 80% of people who get COVID do not see the inside of a hospital. About 20% of them will end up in hospital. And out of these 20%, about a quarter of those are so critically unwell that they have to be on a life support machine or need intensive care treatment. The others have to be monitored and treated with oxygen because they lack oxygen, as COVID tends to affect the lungs in the majority. Unfortunately, it doesn't affect the lungs alone. It affects, as Dr. Moxam was saying, affects the kidneys, it affects the heart, it affects the way the blood clots, it affects brains, and it also affects the way the liver works. So even though the majority of people we see in hospital have low oxygen levels, most of them have other organs of the body affected. So we call it a multi-system disorder. It's not just one organ, but several different organs are affected. Initially in March, treatment of COVID was a big problem because the knowledge base was not strong enough. We gave people antibiotics, we treated them with oxygen when they needed oxygen, and we gave them life support when they needed life support. But if you recall, the mortality, the number of people dying, was extremely high. And when you ended up in intensive care unit, only about 50 to 60% of patients came back. Things have improved tremendously over the last year. We did not know what medications to give. Now we do know what medications to give. We give medications based on research that has been undertaken. We give something called dexamethasone, which is a steroid. We give something called remdesivir, which is an antiviral medication. We put people on special ways of managing their low oxygen by either giving them a lot of oxygen at a very high pressure or using a special mask to deliver air and oxygen into the lungs. And failing that, we also use the life support system. The other thing that we have found is that with the use of what we call contemporaneous research. So I've been involved in when patients come to hospital and be managed for COVID, we enroll those who give us consent into a trial called the recovery trial. And we have tested the use of several different medications with their consent. And that is how we found dexamethasone is effective. And more recently, a medication called tocilizumab has also been found to be very effective. We now have protocols that we use. We know exactly what to do. And the outcome for people who are admitted to hospital with COVID now is far superior to how things were in March. By the summer, we thought things had died down. Things eased up a bit. And then come September, we had a big, huge wave. Now, in my hospital, at the peak of the admissions in spring, I was looking at about maybe 30 patients. And even then, we thought we had been hit hard. On Christmas Day, we admitted about 250 patients, very unwell. In the first wave, we tended to see older people. In the second wave, my youngest patient was 16, my oldest was 99. And it was indiscriminate in terms of who were affected and how poorly they were. And we had to spend many hours trying to support our service. The difficult for us at that time was that nursing staff were becoming unwell, doctors were becoming unwell, and we had very unwell patients. So even though we had the facilities to look after patients, the people to deliver the care was a huge challenge. Thankfully, we seem to have passed over that curve now. At one point in the UK, 1,000, and at a certain point, 2,500 people were dying from this disease. And that's one of the things that struck me. If you hear that there's an illness that kills 1,000 people a day, and you have something that can prevent you from getting it, why would you not take that offer of something that can help you against developing that illness? Most cancer drugs that we give may give up to about 60%, especially when it's advanced cancer, of some resolution. So when you look at this vis-a-vis the things we can do to protect ourselves, then we will obviously we'll talk about that in a bit of a depth later. The other thing is that what I've talked about so far is what we call the acute care. So if you come into hospital, we have a protocol we use. We have now developed what we call evidence-based, based on research, most of it UK-based research. We know how to manage things, and we know how to give you very advanced care, middle-level care, or supportive care as and when we can and is needed. We have noticed that if you're less than 65 and you have even very severe COVID, that the potential to the risk of death is less than 5%. But when you are nearer the age of 90, as Dr. Moxam said, then the risk of death is much higher and goes into the high 80s. And between 70 onwards, the risk of death is also high. As Dr. Moxam mentioned, if you have a certain number of comorbidities, these are other chronic illnesses, your risk of not doing very well is high. That risk doesn't mean that if you have comorbidities, you will get the illness. But what it means is that if you get the illness and you have those comorbidities, then what happens becomes very challenging, and your risk of developing very serious illness needing intensive care or respiratory support becomes high. Now, apart from the acute, looking at very poorly patients, we've also developed a service which you call the post-COVID service. This is a service where 2 weeks after we discharge people from hospital, we discharge some of our patients because they need oxygen for a long time to home on oxygen. And we have what we call a virtual clinic where we phone them every day over almost a 2-week period, try to get their oxygen down and get them off oxygen and then discharge them. And then afterwards, for those who don't need oxygen and those who need oxygen, we do a phone call at 6 weeks, a phone call at 12 weeks, and an X-ray because their lungs are affected at 12 weeks. And for those who do well, we can discharge them. But then a significant proportion of patients we found were not getting better, we're not sleeping well, we're having flashbacks, and almost a condition like what we call post-traumatic stress disorder. Now, I mention this because one may be young and recover from the COVID, but that doesn't mean you've recovered completely, because other organs may be affected. The strain on not being able to get up out of your bed, walk up the stairs, look after yourself, even go up to work is huge. And the implications are financial. If you're a young man dependent on a job that is those kind of difficult contracts, then you may almost lose your job. The psychological aspects are huge. And then the health aspects. If you have a chronic condition like diabetes that has been unveiled by the COVID, you have to decide, you have to then adjust your lifestyle to cope with that. If your kidneys are still not working, you may end up with Dr. Moxam. If your liver is not working, we have to refer you to somebody else. If breathlessness is a problem, it could be due to the heart or the lung, a combination of the two. So there are all those complications when your life has been saved, as it were, the other complications that come beyond that. So it's not as simple as we've treated an infection, you're better, you go home and that's it. So a significant proportion, up to a quarter of patients who leave hospital 3 months afterwards are still extremely unwell. And that is what is called long COVID or the post-COVID syndrome. And so we have also developed a service for that allows us to assess people, refer to rehabilitation, or actually investigate their physical needs. And then there's a psychologist who we use, or a psychiatrist, to help with the service. Now, if you can imagine that 4 million people have been affected in the UK, and if 20% of them ended up in hospital, we're talking about maybe several 100,000. And if a quarter of these have a post-COVID syndrome, then this is going to become a huge financial, psychological, and health burden going forward, and how we manage patients. And so this is just a reflection that I have had. So COVID is not just an acute illness. We know how to treat it now. We know how to manage people when they leave hospital. And for the future, we have a huge burden of people who have recovered that need ongoing medical, psychological, social, and even financial support. My personal reflections on what we have had so far. The one thing I wanted to bring out from what I've said so far is that we should not think that if you do not have underlying health conditions, you will not get COVID. That is wrong. Secondly, if you have no underlying health conditions and you get COVID and it's serious, the risk of death is as high as somebody who has no underlying health conditions. So the first thing is we shouldn't have it in the first place. The other issue that I wanted to bring up is that in the first wave and also the second wave, we've noticed that risk of death from the Black, Asian, particularly Pakistani and Bangladeshi communities, African and Afro-Caribbean communities have been extremely high. A lot of reasons have been assigned to that. Is it due to health inequalities? Is it due to access to health? Has it got to do with race? Has it got to inherent racism in the system? A lot of, is it genetic? Is it due to blood groups? We don't have all the answers, but what we do know is that health inequalities and access to health plays a big role. And this is an opportunity for us all to engage within the health services and find ways of supporting one another to secure health services as and when needed. My final thing is that if you're a Black man and you are obese and you have comorbidities and you get a bad case of COVID, then the outcomes are not good. So this is an opportunity to think about our health, think about how well we look after ourselves, think about how well we seek, how we should seek medical attention if we have any nigglings. And then the other thing is assessing health services should not be a no-no, because we know we are at risk and we should do everything to protect ourselves. And finally, knowing that these risk factors exist, protecting ourselves for the future is really, really important. With respect to the vaccines, we'll be talking about vaccines in the future as part of this program. But I find it a wonderful experience that now we've vaccinated more than 22 million people in the UK. About 1.5 million of them have had 2 doses. And Whereas on Christmas Day, I had 150 patients in our hospital rushing about. Now I'm very happy to announce that we only have 5 patients in our hospital and none of them are intensive care. So it's been wonderful. And I hope it stays that way and we keep ourselves safe for the future. I'm done for now and we'll take questions later. Thank you.
Thank you so much, Dr. Kankam. Thank you very, very much. This is a very useful information, and the very end of your statement has been very encouraging. So I'm sure by the time we go through all of this, it will even get more better. At this point, I will introduce our third panelist. In the name, Sedna. Sedna is the Associate Director for Medicines Optimization in the South London area, Merton Council. She's very knowledgeable, the Chief Pharmacist, one of our own as well, understand our culture, understand our issues, and she will tell it as it is. So, Sedna, please take it over from me and do justice to the topic.
Good evening, everybody, and thank you so much for inviting me. It's an honor to speak to my fellow Ghanaians, and hopefully I'll be able to impart some knowledge, dispel some myths, and help you make the right decisions for yourself. So it's been useful listening to our 2 consultants telling us what it was like before we started the immunization campaign. I will never forget Christmas Day. I've lost many relatives, but Christmas Day was a particularly hard day for me. And it's when I think back as to how difficult it was seeing my fellow clinicians. I am an intensive care trained pharmacist, so I know what a normal intensive care should look like. And seeing the images on TV and seeing my colleagues struggling, doing their utmost best to save very sick people. It was really heartbreaking, really heartbreaking for the people who were losing, but desperately heartbreaking for the staff who were having to be everything to everybody that was on those hospital wards. So hearing that you only have 5 patients now, Dr. Kankam, is amazing, and it's very encouraging. So as Emmanuel said, I'm a chief pharmacist, but since December, I spend my time working in the clinic. So the first slide that you can see, that's me in one of the clinics. I'm responsible for the vaccine jointly with the clinical leads in my borough. And I spend my time in the clinic supporting clinicians, supporting patients, and working as a team to deliver the immunization program. And it's a great joy to hear the effects that the vaccine is having, but I also know that along this journey, we've all had questions, and they're all things that we're hearing. There's a lot of misinformation out there. So I'm hoping that by the end of my session that I've dispelled some myths, I've given you some more information that will help you make the right decision, or to help someone else make the right decision about the vaccine. That's the next one. So why vaccinate? Well, I think from what we've heard, I think it would be fair to say that if we were to rewind the clock back to, say, October, we were all desperate for an answer. Things had suddenly gone for the worse. And the second wave, although we always knew there would be a second wave, I think it would be fair to say we didn't think the second wave would be as bad as it actually was. And in October, we were all thinking, praying that we would find a way out of this. And our prayers have been answered because we now have a vaccine, okay? So why vaccinate? Well, we've heard about the serious disease that, if you contract the disease, how bad it can get. We've heard about how our hospitals were full, and we sadly know so many who lost their lives. So a reason to vaccinate is to reduce all of those. It is actually safer for your immune system to learn how to deal with this virus when it meets it, than it is if you were to catch COVID and rely on that to help you in the future. Because as we know, you can get COVID twice, and people have got COVID twice. And for some people, it's a lot worse than the first time. And I have many colleagues who have had it twice, and they will tell you that it's not something that you want to do. And it gives us the best protection. You know, it's the best, it's the hope that we have. So that's the reason why it's important to vaccinate. And I also want to remind us all at this point that there are 14 vaccines that are routinely used across the world to prevent diseases that many of us as clinicians will never see or have ever seen because of the actual benefit of these vaccines. We take our babies in for vaccination, and with the vaccination program that we have definitely here in the UK, there are days when a 2 or 3 month or 4 month old baby will have up to 5, 6 vaccinations all given to them. And that's something that we routinely accept and has become quite the norm. Next slide, please. So the vaccine is here, okay? It's very effective. And I can say that I've been a pharmacist on almost 30 years. It is the most monitored medical intervention of recent times. We are watching everything that happens with that vaccine. Every single day, the evidence base develops more. We learn more about it. We've all been on lockdown, so we've all had time to learn about it as well. And we've had time to see, you know, credible information as well as a lot of misinformation. This vaccine has been administered to millions. Here in the UK, over 22 million. Since December, I'm working on average 12, 14, 16 hour day. We've all been very, very, very busy. So as well as our colleagues in the hospitals, those of us in primary care have also been very busy implementing this program. But the thing is, even when you're immunized, we still need to observe the COVID safety protocols. And that's for now, because we're learning more and more about what happens when we vaccinate, okay? So for now, once you've had your vaccine, you still need to observe the protocols. But we know that once you've been vaccinated, if you were to get COVID, that it will be a milder disease, it won't be as serious, and hopefully it will not be death either. And getting vaccinated doesn't only protect you, it is about your family, your friends, your community. So we're doing this not just for us, okay? So at the beginning of COVID, if you remember, it was very common for us to say that we were fighting an enemy. It was like being in the army and going to war. And going to war, it was about protecting ourselves during this war, but also protecting everybody we were fighting for and for the people back home. So the vaccine now puts us all in that position. Can I have the next slide, please? So there are lots of vaccines on the market, and they're more emerging. And every country has different vaccines that they're using. But the key thing is that before any country undertakes a vaccination program, that country's drug safety board will review all the information. And based on the information provided, they will give it what we call an emergency authorization to use, which means they've looked at it all and they've deemed it safe to use. Okay, so we in the UK are using the AstraZeneca vaccine and the Pfizer vaccine mainly. We are about to start using the Moderna. In Ghana, they're using the AstraZeneca. I know they are going to use Sputnik. In the USA, they also have the Johnson & Johnson. There are various vaccines, and there will be more coming out, no doubt. So whichever one it is that comes out will be safe for you. And as I say to many people who always ask me, so which one should I have? Should I have this one or that? And I smile at them and say, you know what? If you're invited for a vaccine, you are blessed. Whichever one you get is good for you, okay? So the key thing is that the vaccines had a lot of support in their development, and they've all been developed with the best of the best scientists, the best support, and the best clinicians, the best people testing the safety and quality. So whichever one that you have is good for you. Can I have the next slide, please? Most of the vaccines require 2 doses to confer full immunity. The Johnson & Johnson vaccine is the only one at the moment that just has a single dose. And as I said, the efficacy is developing all the time. But the key thing is, after you've had your vaccine, it takes about 2 to 3 weeks for your immunity to start to develop. So you need to allow that time and then allow time for the second dose to get the full immunity. So the day you have your vaccine, you cannot whip that mask off and get out there and think, right, I'm ready now. No, it doesn't work like that. You need to have your vaccine. You need to wait the 2 to 3 weeks to start developing the immunity. You need to keep wearing your mask for as long as it is the right thing to be doing. And that's what the COVID protocols say. one thing is that each country agrees when the second dose will be given. And again, this is linked to the evidence that's coming out. So when the vaccines first came out, the manufacturers said, well, 3 to 4 weeks, because that's what they looked at in the trials. But the people in the trial are still being monitored, and their antibodies are being monitored as well. And it's becoming evident that actually, the longer you leave it, the better the immunity that you get. So actually, here in the UK, it's 12 weeks. I think in Ghana, it might be 6, 8 weeks. Each country makes a different decision, but ultimately, they all lead to the citizens having good protection. And one thing I forgot to say is that all the photographs on my slide are actually either pictures that that one that you can see in the picture was taken by a colleague in Ghana, and most of the other pictures were taken in the clinic that I work in, and I have permission to share those. Can I have the next slide? So I've talked about the protection, and you heard from Dr. Kankam about the effects of the vaccine. So, every day we are seeing improvements in the numbers. Now, I will never forget Easter, the Friday last year, when I was watching the news and I saw the mass graves being dug on an island in New York, I believe, and also seeing the Italians with a death rate of 1,000. And I remember thinking, my goodness, 1,000. And in no time, the UK was right there too. It was a harrowing experience. So now to start to see all those reduced, even after the first dose of the vaccine, is just fantastic to see. So we are beginning to see our own real life data, and we can see that the vaccines do work. So, why wouldn't you want to have it? It's been a tough year for all of us, and we now have a way out of it. So why wouldn't you have it? So that's the question you have to ask yourself. Why wouldn't I want to do this for myself, for my family, for my friends, and my community? Have the next slide, please. So there are a lot of myths, okay? And the picture that you see there was an interesting one. I was in the clinic when this lady came along, and she sat down. So I was watching them, and I thought, well, that would be a good picture to show my fellow people. The lady there, she's Caribbean, and the lady that sat there, she's also Caribbean, and she was telling the nurse how scared she was of the needle, etc. And I asked her, I said, so what made you gather the courage to come into the clinic? And she said, I thought about it. I thought about my children. I thought about my family, and I thought it was the right thing to do. So you can see her there. She sat there and took it calmly. But she then said to me, a lot of people, she's a counselor, and she was telling me that the people in her area, they're bogged down by the misinformation. So a few myths here, and she said to me, you can use my picture for whatever you want to do, because I just need people to see that it's safe to have this vaccine. A lot of the questions that I get asked, does it have any animal material? No, it doesn't. Does it have any tracking devices? Well, those vials are so tiny and those needles are so small, there is no way you will get a tracking device in there. I work in the dilution room. I am making up that vaccine. And when I have people who are hesitant, I invite them to come in and watch me make it up so that they can see that there's nothing in there. And actually, our telephones are more of tracking devices than anything, to be honest. It does not contain any material that will, alter your DNA or wipe out the Black population either, because the vaccine is shared. Different races have, a dose out of the same vial. And it definitely isn't going to make you infertile. It doesn't alter you in any way whatsoever. Another question I get asked is it suitable for the faith? I'm Islamic, I'm Jewish, I'm Hindu, whatever. All of the faith leaders have given the assurance that it's okay for their followers to take this vaccine. So that's not something that anybody should be worried of. And definitely, I have looked all over my body and that of my colleagues, and we definitely don't have any 666s anyway, okay? So that's not going to happen to you. Next slide. I think it's the last one. So common side effects. So 22 million people have had the vaccine now, so we know a lot about what happens afterwards. If you cast your mind back to when you would have taken a baby to a clinic, you come back after they've had the immunization, they're very grouchy, they might be warm, they generally don't want to eat. It's the same thing for the adults when you have a vaccination, okay? So the common things are pain or slight swelling at the site. I didn't have that, and to be honest, many people didn't. You might have a very achy arm for about 24 hours. Once you take some paracetamol, that's about it. You might have a headache. Not everybody has. Some patients say they do. You may have a high temperature. I've had both of my vaccines. I didn't have a high temperature. I didn't have a fever. You might have fatigue or muscle ache. And I can tell you, when I had both of mine, I was so tired, I didn't notice any different. I was tired anyway. So I did not notice it because I was absolutely exhausted from working in the clinic. But the key thing is that these side effects are transient. They really don't last. Most people will say, well, the day I had the vaccine, I was fine. The next day I felt a bit rough. By the second day, I was fine. And if you take some paracetamol before and after, you will be fine. If the side effects last for generally longer than a week, then you might want to talk to your doctor because it could be a number of things. And it's important that you get checked out. The other thing is that you can report your side effects. If you're here in the UK, you can report them to the MHRA website. In Ghana, they also have, the FDA have a website. So, you can report your side effects. Because remember, we are all collating the information on this vaccine. So every bit of information is useful. And my last slide, please. Infertility and pregnancy. I get asked that a lot. So there is no evidence that the vaccine causes infertility. And to be honest, there's no medical reason when we think of how the vaccine works that it could. For most vaccines, if there's going to be a problem, you will know quite early on. And there are people who were in the trials who've gone on to have babies, fall pregnant, and it's not been a problem. So we don't have any reasons to believe that it causes any infertility at the moment. I also get asked about pregnancy a lot. So it's not routinely offered to pregnant women, although the conversation would be had with a pregnant woman. If they are high risk because they have long-term conditions, they're working in a high-risk area, then that conversation will be had with the pregnant mum, and the vaccine will be offered. I can tell you that many of the female doctors that I've worked with who have been pregnant have had it, and or doctors whose wives or partners are also working in high-risk areas have had it. And the evidence of pregnancy, use in pregnancy is developing, and I know that there are some trials that are looking at this. So that's a space to watch. And there is no evidence that it causes erectile dysfunction. I know that, this is something that a lot of our men, I had a man, two men actually yesterday, two Black men in the clinic, and they came in with their partners to take a photo because they all said, I need to show this to my friends because they all keep thinking that it's going to cause erectile dysfunction. But, I'm going to take this and I'm going to show them because I know that it doesn't. And so there is no evidence as far as we're aware that it causes erectile dysfunction. And I think that is my last slide. Yes. So thank you for listening, and I will take questions at the end of the week.
Thank you so much. Thank you. Thank you so much. We will come back to Q&A, but at this point, I'll bring to you Dr. Mohamed Liman. Dr. Liman was himself a clinician. He was a GP for 15 years in London, has been at the point of encouraging and treating patients. And at one point in time, he has to step back and now also receiving care as a chronic patient. So he has a mixture of both experience, and we want to hear from him. How does it feel like being in a situation like this where you never know the end of it? And then now we have some sort of indication how we're going to end it. So Dr. Liman, please take over so that once you're done, we will go straight to Q&A. Feel free to unmute yourself, please, Dr. Liman. We can't hear you. You need to press the red small sign to unmute.
Can you hear me now?
Yes, we can. Yes, please. Thank you. Please go ahead.
Yeah. Good evening, ladies and gentlemen. My name is Liman Mohammed. I've been a doctor in the UK for the past 40 years. I initially worked in herbs and gynae before I became a GP. I did that up until the year 2010. when I was diagnosed with kidney function failure. I went to the doctor for a routine check, and I was told that I had a problem. To cut a long story short, by year 2012, I had my fistula put in me, and then I started dialysis. I had dialysis up until 2014 when I got a kidney transplant, and that worked for 4 years before I came back to dialysis again. Now, people have to understand that when you are ill, whether you are a doctor or somebody who doesn't know anything about medicine, you have to trust your doctors. The doctors know what they are doing, and if they advise you to do something, you listen to them. The knowledge base they have, from which they are coming from, is very important. And we have to think hard before we argue with them. I'm an advocate for people having the vaccine because I know that prevention is better than cure. For a lot of people in our part of the world, I, for one, I come from Nigeria. We know the history of smallpox, how it was killing people and maiming people in our part of the world before the smallpox vaccine was invented. We all received smallpox vaccine as children or adults, and smallpox today is history. We don't have it anymore. The WHO has declared the world free of smallpox. We are hoping that COVID-19 will become history if we all go one step ahead and take the vaccination. As I said earlier, prevention is better than cure. We have been told from all sorts of religious cycles that even though you pray to God, and in Ghana you say, Jiami, you don't just sit back and do nothing. You have to take it as a responsibility to do whatever is in your own power to do to make sure that this condition doesn't catch you. We give vaccines for children for measles, and what the pharmacist will be telling you later on is the composition of the vaccine we're talking about. There is nothing in it that is unusual. It contains water, a virus particle, a little bit of salt, and nothing more than that. So there shouldn't be any fear. Now, how has it affected me? I haven't had COVID, thank God, but it has delayed my treatment because I was on the waiting list for a kidney transplant the second time. Unfortunately, when COVID came, all the intensive care beds were taken, and the guy's intensive care unit was closed for people who are going to have transplant because the transplant operations stopped. So I'm appealing to everybody who is listening that if you are called to come for the vaccination, please go for it, especially those who are in my age bracket, or older. On the 20th of this month, I'll be 69. And I know from observations and talking to people, those in practice and those out of practice, people who are older than 65 have a higher risk of dying of COVID if they get it, because it's a multi-organ condition. As you grow older, you develop conditions that affect your health just because of your age. A lot of people are lucky not to have anything at all, but the majority will have one problem or the other. And it is absolutely important we do our own to see that we help the doctors. So please, please, I'm appealing. Don't have second thoughts or doubts about why you should have the vaccine. The vaccine is to protect you and the population of people around you. Whether you travel or you don't travel, the people around you are very important to you, and you are very important to them. So please, let's work together and make COVID-19 history. Thank you very much.
Thank you so much, Dr. Liman. This is very encouraging. Of course, you have the bit of both worlds to share with us, and we are very grateful for sharing your personal experience. I'm sure it will help us to understand that it's not only about you not wanting it, but it's also about those around you who otherwise might be in a category of need to be taken care of. So let's not look at ourselves alone. Let's also think about our parent, our grandparent, our uncles, our aunties, those who are in that category, and do this for them, just as others have done for us many, many years. So thank you all, the panelists. At this point, I want to re-emphasize the fact that this program has been brought to you by collaboration from key community organizations, the Ghana Union UK, the Western Region Nurses Association UK, the Ghana Nurses Association UK, and the Nightingale Nurses Association UK. And of course, we have support from World Remit, a money transfer company, and fastest money transfer company I've come across, reliable, trusted, that you can send money to your friends. Without their support and others will probably be struggling. So let's keep using them where we can so they can at least help the community and other initiatives going on. We also have Omega Live TV broadcasting around the world. Omega Live, thank you very much for your continued support, sharing this information to our partners in Ghana and around the world. Please feel free to come back, utilize our website, Ghanaian Community Forum, on social media and get all the information and answers from there. Ghana High Commission is also a partner in this, encouraging us to do more for the community. And so we are grateful for their support. And then Ghanaian Doctors and Dentists Association also helping us in diverse ways. And all your audience who have been coming for the first and second and third and many more to come, without your participation, it will be meaningless to continue. So we encourage you to do the same and invite your friends and family to go to join us. At this point, we will be going straight to question and answer sessions to give you time to be able to ask your questions. But before we do, we will run the second and the third poll to see, after listening to the experts, listening to their experiences and the knowledge that they've brought to us, how do you find yourself as an individual in relation to the vaccines and the related issues that they have addressed this evening? And again, if you have any questions and you want to be called directly to speak, please raise your hand from the chat room. I'll be looking from now, before I come to the pre-event questions, to call on those who have issues that they want to address directly with the panelists. I will assume that the polling, the first and the second poll are finished now. So I'll go through a few pre-event questionnaire that I have received with the panelists. So if we can spotlight all the panelists for us, and then hopefully they will take the questions as they see it fit from their line of experience and knowledge. Right. Okay, I have a question that has been sent to me, and please, any of the panelists can take it. Just go for it. How safe is the vaccine considering that it has been developed so quickly compared to many other vaccines that has been made available in the past to humanity? How safe? How do we assure anyone that this one is exceptionally safe when it took well over 5 to 10 years to bring a vaccine for polio? or otherwise other vaccines in the past?
I'm happy to answer that. So rewinding the clock to a year ago, wind the clock back, the world was thrown into a pandemic. And I like to think that we wouldn't see another pandemic in our lifetime. So pandemics are not a common occurrence. We were in a situation where we needed to do something, and we needed to do something quickly. The vaccine was developed with immense collaboration from all parties that are involved in vaccine delivery. The other thing too, I think people need to remember is the process. So I was a clinical trials pharmacist in a previous life. So I've been involved in clinical trials. And quite often with clinical trials, the phases of the trials are done sequentially. So you do the first bit first, so you test for its safety in animals or in the lab, and then you do it in healthy volunteers, and then you progress on to what you're looking for efficacy, so does it work, and then you continue monitoring patients. What happened with this vaccine was those phases were overlapped. And the reason that they were overlapped was to try and get this vaccine as quickly as we possibly can. The other thing was that all the companies that were developing the vaccine were sharing information. So normally when companies are making a vaccine or a drug, it's top secret. They keep it under wraps because obviously it's got huge financial implications for the manufacturer, and they want to keep it all quiet. But not with this vaccine. There was a lot of collaboration. People were sharing everything that they were finding with each other. The other thing was that the financial risk for for developing it, because normally you would have to develop it, get it through the marketing authorizations, get it licensed before you even start to make it available. But this time around, the government's backed it financially. So this is a product that has not had the level of backing that a product has ever had in history, I am sure, because everybody was behind it. The scientists were working together. Our healthcare colleagues were all stepping forward to be in the trials. So that was the other thing. This is probably a trial that's had probably more healthcare professionals involved in it than other trials, because we were all desperate to have an outcome that would mean that we could come out of this dreadful position that we were in. But there's one thing I can tell you, and that is that there hasn't been a shortcut taken in terms of the robust testing of the products. So none of the companies, the FDAs or the MHRA, none of them took a shortcut in making sure that this is safe for us. So you don't have to worry. You need to feel assured that, we have learned from vaccine delivery over the years. There was a lot that was brought forward when this vaccine was being developed. The technologies had all been used before. The scientists had done the work before, and it was an opportunity to use it. And it was an opportunity for them to collaborate to come up with these great products that we now have. And as we're beginning to see, they work and they're safe.
May I add something to that, please?
You can.
Yes, brief, yes.
I want you to stress the fact that the knowledge base has increased extensively in medicine. The knowledge of virology and transplant medicine indicated that studying the virus was much more easier than it was before. Our knowledge at the time of smallpox and measles was not as extensive as what we know today about virus and how it replicates and how to deal with it. So that contributed immensely in the way the vaccine was developed quickly. A lot of people would be saying, why is it that there's no virus yet for HIV? That question is a difficult one because HIV has been with us for some time, and up to now we don't have a vaccine. But take it that people are working on it, and one day we will come and deal with that as we are dealing with COVID-19 now. Thank you very much.
Thank you. Thank you. The next question from me, for those who sent it earlier. What is the percentage of chances of survival for somebody with multiple comorbidities? So I think the person wanted to find out if there's somebody with diabetes, blood pressure, and asthma, compared to somebody with just one comorbidity, what are their chances of survival in that circumstance? If yes, Dr. Manson, please, if you want to, and I'm sure others can contribute.
Yeah, so the data that I showed actually came from a risk assessment, two commonly used risk assessment scores that you can put your own individual data into, and it will come up with a calculated risk for you should you actually acquire the virus. Now, all of these things are risks, and it comes out as percentages. And of course, if there are 100 people like you, then of those 100 people, say 60 or 70 may die as a result. But it doesn't, obviously it's not 60% of you, it's 100% of you if you are somebody who has a bad outcome from infection. But there are risk calculators out there. They're very widely available. Most of the chronic disease support groups and networks, so Kidney Care UK has a link to them as well, because they're really, really useful to help inform individuals about how to look after themselves, particularly around work. And if you're nervous about going out to work and you want to have a sense of, should I be putting myself at risk? Am I really at risk by doing that? You can put the data that you have about yourself into those databases, and it will tell you what your risk is. It's quite useful to do it with somebody who can help interpret it for you. And also, obviously, it doesn't take into account the avoidance of getting the infection in the first place, so wearing a mask, socially distancing, and it also, at the moment, it doesn't take into account the effectiveness of the vaccination either. But it certainly is, there are ways out there of calculating your personalized risk.
Yeah, and just to add to that, Dr. Moxham, yes, the risk calculators are predictive calculators. So they will give you a prediction. It doesn't mean it will work for you as an individual, but if you take, as Dr. Moxham said, if you take 100 patients and you expose them to the same degree of illness, what will happen to them? There's a risk calculator determining what your outcomes will be depending on your age, sex, the number of comorbidities you have, and your race, etc. And that is used by the Association of Occupational Health Medicine. But also, when you come to hospital, there's a predictive risk we can use to calculate the risk of how well you do or not. And that also helps us determine how quickly or how aggressively we treat people when they come to hospital. But it doesn't work for the individual. It's based on what we experience from the population as a whole. So yes, they are risk calculators, but they are predictors rather than specific risk for the individual.
Okay, thank you.
But just to add to that, we know that if you have a certain age group and you have a serious illness and you end up in hospital, then the outcomes, if you are 80 years, is not as good as if you are 25 years old.
Right, thank you. There's somebody's hand on the chat room up, and I will be calling them, and then I'll return to the pre-event questions with you. If I may call Winifred, I've seen a hand up called Winifred's iPad.
Yeah, that's me. Thanks, Mr. Kwaisin. So the question I want to ask is, during this pandemic, a lot of people have received letters from their GPs for them to shield for one reason or the other. So I have a close relative who has hypertension and is on 2 medications to control it, and is taking long-term medication for DVT and is pre-diabetic. And obviously with the general risk of being BAME and nearly 60 years as well. And even since the second assessment, I mean, there was a group that came to say, to increase the risk and add more people on the list of those who needed to shield, and has still never had any invitation from the GP to shield. What was the criteria for selecting, or is there not enough evidence to prove that this person is genuinely high risk? And the second question I want to ask is, obviously, a lot of people are following the news religiously these days to pick on information, and there's a lot going on with the AstraZeneca vaccine, which people are concerned about because of the DVT, that has been linked with the AstraZeneca vaccine in the past few days, not in the UK generally, but in other countries. Are people meant to be concerned about, taking the AstraZeneca vaccine?
Thank you, Winifred.
Thank
Please,
you.
anyone can feel free to take the response to these questions.
Okay. Sorry.
Yes, if I want
please.
to
Carry on,
yes.
No, I'll answer the AstraZeneca bit, the pharmaceutical side, and maybe you can answer the side.
Yes.
Yeah.
So if I were listening to you,
Yeah,
if you want
okay.
to,
yeah.
Okay, I'll talk about the DVT associated with the AstraZeneca vaccine. So I think in Denmark, there were 4 patients who developed DVT, and there was one lady who actually died from blood clots 10 days after she was vaccinated. So all these events are being investigated, but I don't think all the patients came from Denmark. So all these events are being investigated, but so far it looks like it's not linked to AstraZeneca, and also the incidence of blood clots in patients who have had the AstraZeneca vaccine is much lower than what you would expect in the general population. So, these things just get blown out of context, and all the other countries who have postponed the use of the vaccine for 2 weeks are just watching and waiting. It's not like they've experienced anything. So now, if you think of the number of patients in the UK who have been vaccinated alone with the AstraZeneca vaccine, it's over 10 million people, and we haven't had any reports of DVT. And also, one thing we do need to bear in mind is this vaccination is to prevent you from severe illness, hospitalization, and death from COVID, but it's not preventing you from getting other diseases that you would normally get. So people, we will expect people to die after they've had vaccines, because that's just life. So, it has been blown out of proportion. It is being investigated, and the number of people who have had blood clots from being vaccinated are less than what you would normally expect in the population. So far, so good. I wouldn't worry about it at all. So yeah, that's all I wanted to say about that.
Thank you. Dr. Kankama, if you want to add to anything.
Yes, I was talking about mainly about the shielding bit. It's almost like an algorithm, just like we did with the schools, the GCSE algorithm. You look at the information we have now is what we call population-based information. So the people who are selected to be for shielding, if apart from race, you look at his BMI. If is a BMI high, they look at the diabetes, how well it is controlled. Does he have heart failure? Does he have chronic kidney disease, etc.? So unfortunately, are they more than 65 years old? So based on the population information we have at the moment, we know that if you are more than 65, you have more than 1 or 2 comorbidities. If your BMI, which is whether you're obese or not, is high, then you neatly fall into that category. But there are people who don't quite fit into any subset, and some of those people get missed out. My advice is contact your GP, tell them that I'm 1, 2, 3, 4, 5. I feel I need to be shielded. Do you agree with me or not? If you don't agree, why not? And if you agree with me, please send me the letter, because we are empowered to do so. So if you feel strongly about it, contact your GP, and then if they need to, they'll do that for you.
Can I also add to that? GPs also can take you off the shielding list if you feel you shouldn't be on it, because people have received the letters and they feel they shouldn't be shielded. And, so you can go to your GP and say, well, why have I been put on the shielding list? And you can have that conversation with your GP, and he can actually take you off it also.
And I think the most recent expansion of the shielding or clinically extremely vulnerable groups is to try and expand to include particularly people with learning disabilities, to get them vaccinated, get your access to vaccination much, much sooner, because if you're under 40, there's a couple of months to go. And actually, if you have something like Down syndrome, or you have a relative who has Down syndrome, we know that their risk if they contract the virus is extraordinarily high. And therefore, it's to allow access to earlier vaccination in groups that are now believed to benefit more from earlier vaccination.
I think one thing we have to remember is that the virus its own doesn't move. It's people that move the virus. So if you are affected by a chronic condition and you are not protected by shielding, it means you are free to move about. And as you move about, you meet people who inadvertently have got the virus, but you do not know. And if you pick it up, it will affect you adversely, because your immune system is not as strong as that of a healthy individual. And that is why shielding is prescribed. And it's absolutely important not to fight the prescription, because it's in your own interest and the interest of those people around you. That's all I have to say.
Thank you so much, panelists. On that note, I have more questions coming. I've got people's hands up. But in view of this, we have a combination of community leaders who have come together and taken the vaccine themselves. There are people from all walks of life, from different Ghanaian cultural background. And we have a video that they've put together in collaboration with Wesley Chapel. Wesley Chapel is a Methodist church in the city. And I will create your indulgence to show that video for the next 5 minutes while you take a break and grab some water to, calm yourself, things down. We'll show that video and then we'll come back to the Q&A.
Ago chame kenyame. Acho mi Albert Papu Johnson. Mi iri fatalo tamase chole Elizabeth Johnson. One time ni ufemo anali ke. Wana where COVID vaccine chofane. Ni se sani fonko pekra. Where Bujake enyo wo ke woku ke wokuchum bi fen he bana fe ni wokamo helane nyaha woyia amla lo gbajia no toleano no jiake ke bale moke moshiramo oka benke wo hicho wabumo wahi ha ni ji mask face mask ni wofo wode fomo petio hu yin kome fe mo ha wo fe ni ha wo fe mo twa do manya blawo.
My name is John Kunuto, mechanical engineer, retired. Nkonye John Kobla Kunuto, mayivedo abisika wona COVID dolela. Wo abisia wonyo na watoshia botana mashiama. Aye edo womnye ha. Abisia dodo na nagaba nyengto nyapema nolao. Planya to manolao miagadze dove vien o. Abale si wole ndudo blom na miene la mina mia no zogeno so mia ne ogbo. Mia no nutom enu pakple ngochi eye mia kloshi eji. Mia tenwadu edo voni si aji ne mikata mie sonu. Akpena mi.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuhu. Sunana Hajjajara, Sarauniya Hajjajara Shado. Ni chartered accountant ni kuma community leader ne daga UK. I mini coronavirus vaccine, Oxford AstraZeneca version, ba masala kan wannan vaccine.
ina jiran na biyu da za a yi mini. Don Allah yan waye na, iyaye na, kannina, aka kira ku yadda ku je a yi muku vaccine. Saboda annoban gan da ya zo, COVID vaccine ya taimaka ma kowa kar mu kamu da wannan annoba. A yi ta tsayawa nisa da juna da taro, a kuma wanke hannu sosai, a kuma sa face mask. Mu duka tare mun yi nasara da wannan annoba cuta, insha Allah. Da ikon Allah, ni ne naku Sarauniya Hajiya Shado.
Ibizolami nguMary Sibanda. Isikhathi sami singafika sokuthi ngihlatshwe ijekiseni ye-COVID-19, ngizahamba ngiyehlabisa. Ijekiseni leyi iphephile njalo iyasebenza ekuvikeleni umkhuhlane we-COVID-19. Ukuhlabisa ijekiseni kuzavikela mina, wena, umndeni lomphakathi ukuthi liphephe emkhuhlaneni we-COVID-19. Ngiyalikhuthaza ukuthi liqhubeke ligeze izandla, ligqoke ama-mask njalo lingaminyani. Singabambisana ukulwa lalo umkhuhlane sizanqoba.
Anam na atofo mechia munyi na aye muni ajojana na menyamo rekase mawo panze a oye vaccine ma yaruba abe COVID-19 mawo bi na oye papa nti woso bombozen na hwehwe chiri kwan na wobi usande mfumu biara enyu boni biara enyu na mesha mu nkran de se ewo bi a ebowo ebusua ho ban ne bronwa etido nyinara ho ban ma obaya won so yare bebi renka hwan nti menanum na mejam mesra mu pi mombo mbodin a na nsama ya tete wo ho nyina onye nokwar na monwo pande nibi afi so sa yehie ma mumma kwaninda yen ntem kakra ma obaya ayem bembe ayen wa so obi wo bi a sabe oron fansan nnua na yambo yan ho ban yankodo so yanhokoro yansa ho na sensu na semina so nyi ho a yamfa apapansa ho a oye sanitizer eduruwom na yamfa ono so mpapa yansa ho misramu pi oye papa pada yen nyinara ya bobom na ya wo pandi bi ama yen nyina ye nya hoto medam masipi
zida ndinozipa na basi masukumi ndakabayiwa nomba ye COVID-19 kubayiwa nomba akuna njodzi uye kunokosha pakudzivirira ichi chirwere. Kubayiwa nomba kuchadzivirira ini, muri yangu newese wemunharaunda yangu pachirwere ichi. Chengetedza mutemo wokusiya zvinhano pakati pako nevari pedyo newe. Pfeka maski yako nekugeza maoko. Tikaita izvi zvese tose tichakunda.
At World Remit, we understand what the journey is about, how it can sometimes take a little distance to bring us a little closer together. With ways to save more when you send more, World Remit is here for you, so you can be there for them.
Yes, and so welcome back. Apologies for those who otherwise wouldn't understand this dialect. It's just for those who have taken the vaccine to share with all of us on this platform and allay some of the concerns from them. So we'll go back to the Q&A with some of the questions that I have here. Next question that I have is, was the vaccine tried on different variety of people with health conditions, either well people, young people, and people with comorbidities, or it was just tried on people who are fit and well? I don't know if anybody wants to answer that, because somebody wants to know whether there was a section of diabetic patients that was tried on. Was there any people with asthma or any sickle cell patients that were, the vaccine was tried on, or we only considered those who are fit and well before we approved it?
I can answer that. So I've had a look at the study participants for both the AstraZeneca and the Pfizer vaccine, and it was tried on a range of people who had a range of conditions in a wide range of countries. So for instance, in South Africa, Brazil, Argentina, the UK. So, in Black people as well, and with multiple conditions and a wide range of ages. So yes, it has been tried in such patients. And also, I must say, these studies had more participants than any vaccines that we have ever tried in the past. So the numbers of people were just incredible. There's been no vaccine study that had that many people, because I've also worked in clinical trials, and you have to wait for people to be ill before they get enrolled onto the study. But in this case, it was a pandemic and the disease was running wild in the population. So it was really easy to get people who had, who could catch COVID, and then people who did have COVID. They will have 2 study arms, and they'll give the vaccine to one lot of people, and the other people didn't have the vaccine, and they compared the number of infections in both of the study arms. And that's how they were able to find out how effective the vaccine was.
Can I contribute something here, please?
Yes, please.
One thing we have to understand is that the way the human body works is the same for all of us. There's no difference. Where the difference is when you have a condition that is not controlled. If you are hypertensive and your blood pressure is controlled, your body will behave like that of a healthy person. If you are diabetic and your blood sugar is controlled, your body will behave like that of a normal person. So there's no real difference. It's when the condition is neglected or not treated that the problem arises. So we shouldn't confuse anybody that because you have a comorbidity and you are on treatment, your body is different. It isn't different. It's exactly the same thing. All you have to do is to listen to your doctors, take the advice they give you, the treatment they give you, and stick to it religiously. If you do that, your body will behave like that of a normal, healthy person. And when you receive the virus, the body will recognize it, the vaccine. When you receive the vaccine, the body will behave like that of a normal person and say, hey, there's something foreign in my body. And the body will mount a challenge to that foreign object, which is a virus particle. Not a live virus, but a virus particle. The body recognizes it as foreign and develops an immune response against it, which is what it will do when the real virus comes to your body in the future, if it does, and it will fight it and defeat it. So let's get that clear. The human body is the same.
Thank you. Thank you very much, Dr. Leman and Efa. The next question is it safe for persons diagnosed with autoimmune diseases to have COVID vaccine? I don't know if any of you want to share.
Well, as far as we know, there isn't any group of patients that can't have the vaccine other than those who have an allergy to the components of the vaccine. And obviously, at the moment, with pregnancy, like I said, then there's a discussion with the pregnant woman, looking at her risks, explaining to her, looking at her risk versus the vaccine, and a decision is made. So yes, people with autoimmune diseases can have the vaccine. And in actual fact, their autoimmune disease puts them at risk. So it's very important that they have the vaccine.
Thank you.
Regarding the pregnant woman, it's not that the vaccine is dangerous to the pregnancy. What we are afraid of is that you might develop a mild fever, which can affect the progression of the pregnancy. The vaccine itself doesn't harm the baby. Let's get that clear. And because from experience, the temperature rise that we notice with the immunization is not high enough to cause a miscarriage. So really, people are just taking an extraordinary precaution when they advise pregnant women to think before they get it. There is no real evidence to suggest that it's going to affect the baby. But because of the fact that the side effects include developing a fever on its own can lead to miscarriage. But the temperature rise we see with the vaccination is not high enough to do that. So I hope that will clear the air.
Thank you very much. I'll go to the chat room. There's somebody called Irene. Irene, if you want to unmute yourself, please, and put your question forward, and then I'll come back to others.
Thank you very much. My question is, obviously, normally when you have a live vaccine, you are advised to wait 4 weeks prior to having another live vaccine. You have to have them both together on the same day or wait 4 weeks. With COVID vaccine, we don't know much about it. Can one of you confirm if you can have it a week after you've had a live vaccine or any other vaccine or not?
The vaccine we're talking about is not a live vaccine. It's a virus particle that is being given. And if it's given, there's no reason why you cannot have another vaccine at the same time.
I can just add to that. So, for instance, the doctors are advising that if, let's say, you have the flu vaccine, you need to wait at least 7 days before you have the COVID vaccine. And as Dr. Liman has said, it's not a live vaccine. If you do catch COVID and you need to wait 28 days or 28 days after your symptoms, 28 days after you tested positive before you can be vaccinated. If you're ill also, you have to wait until you're well before you get vaccinated. Irene, you want to ask some further questions? You need to unmute yourself. Thank you.
Irene, do you have any extra, or you will be fine for now?
She needs to unmute herself. You're muted.
Yeah, okay. I'm aware that it's not a live vaccine. However, I work in occupational health myself, and I've had on several occasions students and staff telling me that their doctors have advised them that even though it's not a live vaccine, they should wait for probably when they are coming for hepatitis B vaccine. They say, well, because we don't know much about the COVID vaccine, they should wait, say, 2 weeks because we don't know much about it. And then when they have to come for their BCG, whilst I'm aware it's not a live vaccine, they are being advised to wait probably 4 weeks, which I know it shouldn't be the situation.
I think initially the advice was, this was in December when it was very first rolled out, that we should advise people to wait 2 weeks. And I think that was about data collection with side effects from the vaccine. So we need to be clear it was coming from your coronavirus vaccine and not from another vaccine. However, over the last 2 months, that's reduced down now to 7 days, the advice. And I think it may even be less than that now because we have more experience and we know what the side effects are. I think it is important that we don't delay having your coronavirus vaccine because you've had another vaccine or somebody's had another vaccine too long, because the worst case scenario is that you delay it by 2 weeks and you become infected in that time. And that's obviously devastating.
Yeah, in the clinic, we say 7 days. So it's just really leaving 7 days clear of the coronavirus vaccine from other vaccines.
Okay, thank you very much. There is a question from somebody in an email to me just now, and I just want to summarize it because it's a lengthy email. Is it true that any part of the vaccines or any of the vaccines that are out there was tried on aborted baby cells? Is there anyone that can speak to? I know you've given indication about the content of the vaccine, but there are theories that some of the vaccines were tried on aborted baby cells. I don't know what that means, but
I can answer that. So the Pfizer vaccine, in the initial stages when they were doing the exploratory work, they did use a fetal cell line that was from 1973. So that's for the Pfizer vaccine. Now, with the AstraZeneca vaccine, to harvest the vaccine, they had to use the same cell line from 1973. However, in the finished product, there's no fetal material.
right. Okay, so it's important that we clarify that. Thank you very much. Let me go to the chat room and see if there's anyone raising any questions there. Okay, at this point, I think we've given enough information, and we'll come back to the quick Q&A. We will run the next poll to see where we are with ourselves as a community, and then we'll come back to the Q&A. I've got a few questions to come. Okay. While the poll is going on, permit me to acknowledge the support and the presence of Ghana Union Harlow. Ghanaian community in Harlow are here representing, and we thank them for their participation. Ghana Union Reading are also here. I have seen them on the chat room. And we have, of course, Ghana Union Midlands also here. All these organizations are doing a number of these events within the areas, and I encourage you to join from time to time, and let's keep the conversation going. At the end of it all, our interest is to make sure you are fully aware and you have the information at hand to make the decisions for yourself. Nobody's here to give you any decision. We just want you to get the fact, so that when you are out there, you are well vested in the information that you need to have at your fingertips when it comes to COVID and the vaccine. We've gone through a year now, and it's about time we all have this information at hand. So thank you all for joining, and all the other organizations that are here, we want to welcome you. I guess the poll is done. And the next one is also ongoing. Okay, so the next question I will have for you from the list of questions that I have, does the COVID vaccine have a chip in it? And I know Sedna mentioned something that has nothing like 666, but there are people still thinking there is a chip in it that will chase you everywhere you're going and track you down, and it doesn't help with all this tracking and tracing going on here and there. Can somebody clarify that at all, so that when they take the vaccine, they know they are not carrying a chip in their body?
Absolutely no chip in it. And actually, like I said before, the mobile phone that you carry probably enables you to be tracked far more than any vaccine ever will, for now anyway. So no, there is no chip. There is no chip in that. And I do have people asking that question all the time. It's an interesting concept as to why people would think that there's a chip in it. There isn't, actually. All that's in there is the virus protein and the additives that you need to boost your immunity to the virus. And that's it, really. The contents of the vaccines are available in the patient information leaflet. So when you come into the clinic and you have the vaccine, you're given the patient information leaflet. It's available online. You can have a look at it. There is no mention of a chip in there. So yeah, nothing to worry about.
Thank you. Thank you. The next one is, how does it look like for somebody severely ill patient in an ICU? What are the process that people go through from being ill to being treated and, where possible, with a bit of hope, recovered and being sent home? Can somebody talk us through some of the things that the physicians go through to get that person to that far? I guess Dr. Kankam, you may want to, yes.
Yeah, I can chip in here. As I said earlier on, it's only a small proportion of people who end up in hospital. The usual problem people come to hospital with is extreme breathlessness and what we call hypoxia, which is extremely low oxygen levels. Now, if we go back to basic biology, there's something called the red blood cells, which carries oxygen around the body. Now, it gets this oxygen from the lungs. So our heart pumps blood into the lungs, and the lungs enrich it with oxygen and it goes around. So the blood looks bright red. Now, because the lungs are so damaged by COVID, the ability of your lungs to absorb oxygen from the environment is very impaired, to the extent that it's not absorbing enough oxygen when the blood goes through. And so you feel as if you've run through, done the London Marathon twice over. You are breathless and you are panting for air because your lungs are not capable of enriching your blood with oxygen. And that is what we call it hypoxemic, we call it respiratory failure, because the ability of your lungs to enrich your blood with oxygen has failed or severely impaired. And so the first thing you would notice if the ambulance crew, A&E, etc., is that an oxygen mark is stuck on the patient's face to enrich the amount of oxygen going into the lungs. Normally, when we breathe in air, we have 21% oxygen. And at that stage, the 21% oxygen is not doing the work. It's not doing the trick. So you have to increase the amount of oxygen. And you hear about 50%, 60%, 100%. So the first thing to do is to make sure that the oxygen levels are at an adequate level. And we do that by, people buy pulse oximeters where on the finger, you check how much oxygen is in the bloodstream. And it just tells us how much the blood is sufficiently absorbing the oxygen you breathe. So anything below a 90 and far lower than that is not acceptable. So we give oxygen. Now, in my talk, I said that various organs of the body are affected. So the blood pressure may be low, in which case we have to find a way of bringing the blood pressure up, usually by giving fluids. The kidneys may not be working very well, and the fluids help there. They may have an additional infection on top of the COVID, so we have to think about giving them antibiotics. So the first things we do, we follow a protocol called ABCD, where you look at the airways, how well they are breathing, what their blood pressure is, whether they have any other problems and any other disabilities you can pick up. So occasionally when you come to the front door, we would do, well, usually we do a chest x-ray to look at your lungs, and COVID has a classical way, classical picture when you do a chest x-ray. We do blood tests. There are particular things we look for in COVID, looking at the white blood cells, looking at the signs of infection, and looking at how the kidneys, the liver, and the heart are functioning. And we also do something called an ECG, looking at the heart, because we know the heart can be affected. So these are the first real assessments. And then based on what we find, we can make a determination as to how poorly or how sick you are. If we think you are extremely poorly to the extent that if we don't act very quickly, you may lose your life, then we take you to the intensive care unit. And the intensive care unit provides supportive care. So we look at your kidneys, we look at your liver, we look at your lungs, we look at your heart, and we try to sort out all the abnormalities there. If you are not that poorly and you can be managed in the general ward, then usually it's giving you oxygen and also giving the other medications. And I talked earlier on about giving steroids, and then we give something called dexamethasone, which is a steroid. And there are other medications now we can now give called tocilizumab, which we give on intensive care on a general ward. In addition to that, in the UK, most facilities have something called the recovery trial, which allows us to use other medications, such as what we call monoclonal antibody, which is a made-up antibody to fight infection. We're also using aspirin and other things called other medications to see whether it helps the recovery process. So, and then over the next 4, 5, 6 days, we see how well you're doing. If you are doing well, then we notice that the amount of oxygen required gradually goes down to the extent that we can take you off the oxygen altogether. If things are not so good, then sometimes we have to end up on an intensive care unit and then again support the various organs. And then finally, we have something called remdesivir, which is an antiviral medication. It doesn't cure the infection, but we have noticed that when you use it early in the disease process, then people get better quicker. So these are the things we normally do. Unfortunately, for a select group of people, despite all these efforts, the outcomes are not great and they may lose their lives. Now, once you get off oxygen, we start getting you up and mobile again. If you go on a life support machine, you normally spend 3 to 4 weeks to almost 6 weeks in hospital, because sometimes once you get over the acute illness, your muscles are weak, your heart is weak, you may have blood clots, etc. And all those things need to be tackled before you get out of hospital. So it is not a straightforward case for everybody, but for the majority, we give oxygen, we give the steroids, we give the antiviral medication, we'll get you on the trial, and usually within 10 to 14 days, most people are out of hospital.
Right. Okay. Thank you so much. At this point, I think we will show you the next event that will be coming up before we come to our last 2-3 questions that we have with us here. So if our IT team can show us the next event, we will be looking at COVID-19 and the vaccines, benefits, risks, and mortalities. COVID-19 and the vaccines, benefits, risks, and mortalities. And we have, again, experts vested in this field that will articulate the issues around those topics with us. So we encourage you to join us and be part of the conversation. Thank you very much. Information will come around to you in various ways as we go along. We will also share the poll results so far that we have to see where we are at the moment, and then from there we'll go to 1 or 2 questions and we'll bring it to a close. At the beginning of the session, we did ask how likely are people to accept the COVID vaccine. We had 53% of people who had already taken it, which is a good news among our community, and we had 8% who are still not decided, and 13% unlikely. So the next one was, how likely were you to accept the COVID vaccine when offered? Sorry, that's the second one. Has today's session addressed your concerns? Yes, 52% says yes, it has addressed a lot of concerns they had, as compared to 3% who will still rather wait for more information, which is still okay. Then that is why this forum will still carry on, and we'll make sure everybody's question is answered in the course of time. And has the next session is, did you find the awareness forum useful? 95% said yes, they find it very useful, and we will continue to make it more useful. We will bring you the subject areas that matters to our people, and with the help of the experts who volunteer their time for free, we want to thank them, but with their help, I'm sure we will give you nothing more than the right information on this platform. Thank you so much for sharing the poll results, and we will go back to Q&A with two more questions left, and hopefully we will bring this to a close at the rightful time at 8 o'clock as we anticipated. The next question that I have with me is, why does COVID impact some people more than others? That is the question that has just come through. Why does COVID impact more on some people than others? So, for instance, if you take two people of male gender, all age 50 with no pre-medical conditions, why does one suffer more than the other? If any of our panelists can clarify.
You know, I don't think anybody really knows the answer to that. And that's why the statistics are the statistics. So they are numbers, they're not people. But within those statistics, you know, the risks are there. I think, you know, if you are in a group where if there are 100 of you, then 60 of you or 70 of you may do badly, then, you know, the problem comes that actually if you're one of the ones that does badly from it, then, you know, it's 100% for you. So I think it's really important to be aware that actually the risks are present, but it does not mean that everybody's going to get sick if you get the virus. It also, we know that even if you're over 80, the vast majority of people don't have a very mild form of it, but the risk, the percentage risk is much, much higher still. And if you do get it, your chances of becoming much less well are higher. There's ongoing research all the time to try and work out why particular conditions are predisposing people to worse outcomes, why some individuals do worse than others, and there's going to be it's going to be multifaceted. So there will be lots of contributing factors. So it'll be around your genetic makeup, the nature of your condition, so how well controlled your diabetes is, for instance, how well controlled your hypertension is, which specific medications you're on, what dose they're at, what level they're at, and also, you know, your BMI and your fitness, and it comes down as well to the dose of virus perhaps that you're exposed to. I think there's good evidence that if you're the second or third person in a household to become unwell, then actually you may they're more likely to have a higher dose of inoculation. So that's how much virus you actually contract, and that has a bearing on how severely unwell you might be. So there's lots of different factors, some of which are about the individual, some of which are external to the individual. We're learning all the time.
Thank you. The last and not the least, I would say, what are some of the vital organs that COVID can attack for those who never had comorbidities at all if they get it as part of long COVID? That's what they said. Is there any vital organs that COVID will attack that you probably not recover from after the vaccine, and it will become a recurring situation for you?
I think I, at the beginning, said COVID is a multi-system disorder. So it attacks all and every organ. The commonest ones are the lungs and the kidneys and the heart and the liver and the muscles and the brain. So everywhere. The one thing is that when you treat the respiratory, the lung side of things, the other things that happen, which we've all heard about, are the blood clots. So people can have blood clots, we call the pulmonary emboli, and it can happen several weeks after you leave hospital. It affects the heart, and the heart's ability to pump blood around the body, called heart failure, becomes an ongoing problem. And it can be a lifelong thing because of the inflammation on the heart. It can affect the kidneys, and some people end up on dialysis as a result of their COVID. And then there are the other things I talked about, long COVID, which is almost like what we call chronic fatigue syndrome. So you are tired, you're unwell, you can't sleep properly, you spend all your time in bed. And that is a dreadful situation, especially for young people. So that we are learning, as the politicians showed us at the beginning, we have to be guided by the science. So the knowledge is being gathered and is being collected, and hopefully in a year's time we'll be more precise in how we go about this. But this is one of the things I say, if you we have to avoid getting COVID, because if you do, you don't know what the potential long-term consequences will be. And then the other thing to say is that when it comes to long COVID, we think that rehabilitation, psychological support, etc. helps, but we don't know what the future holds. So hopefully, if we do the same thing in a year's time, we'll have a lot more information, we'll have a lot more knowledge that one can share.
Thank you very much. If there's
I just
anyone that
wanted to add. I wanted to add to that. I read somewhere this week that people who've had long COVID have benefited from having the vaccine, and the vaccine has improved only in about 30% of people who've had long COVID, but the vaccine has improved their symptoms a bit. So even if you've had COVID and you're still suffering, you know, it's advisable to be vaccinated, even for that reason as well as preventing getting it again.
Thank you very much. And I think that takes us to what Dr. Kankam said, that we should avoid having COVID in the first place. So hands, face, and distance is still a key message from us as a community. One last question, which has just dropped on my WhatsApp now. Is there any evidence to support speculation that Oxford AstraZeneca vaccine causes thrombosis?
That was in the chat. I think someone sent it directly to me and I attempted to answer it. But did we not talk about it? I thought we did discuss it. Yeah.
Right.
So, yeah.
Perhaps they didn't get it quite clear. So if you want
okay, I'll just say it really quickly that the rate of thrombosis in people who were vaccinated with the AstraZeneca vaccine is much less than what it is in the general population. So it's highly unlikely that the vaccine is causing thrombosis or